Hello, everyone. Welcome to our Zoom meeting. Today we will discuss three or four topics. I'm going to start with just a reminder for all new fellows or those who are interested. We have different topics or projects that are ongoing. So I'm going to share the screen and show you how to uh, join any of these teams. So if you go to the app, on top you will find some on the menu, the projects. You can find different projects that are listed. And if you are interested in certain topic, AI, for example, you will have a list you can share. You can search for some of these. Uh, For example, if you find this interesting for you, the role of social support, networking, sustained use of mobile health applications, what you're gonna do if you are really interested, just add your name, hit add, and your name will be listed among the team members here. So some of the members might be a project leader or just team member or author to submit and so on. So the role is different for each one of you. You can assign yourself as any role you like. Uh, and this is how you do it. So you add here, you add your full name, example, and then you add, I want to be a member or I want to be a leader or so let me just here and then your role or task that you want to, if you are interested in just preparing the poster or presenting or drafting the preparation or video. So you can just present that and then submit. This is how you add yourself to the team. And when you're ready, you can contact the team leader and then they can arrange for your task and so on. Dr. Ahmed was asking about that. But for now, I'm gonna move it, hand it to Dr. Mahasin and her team. When you are ready, Dr. Mahasin, welcome to the program. Thank you. Dr. Mahasin, you are muted.
Oh, okay. Sorry, Dr. Nader. So, the agenda of today, we will start with Dr. Malaz. So, Dr. Malaz, if you are here, you can start. Dr. Malaz, you are muted.
Hello everyone, hope you are doing well. Hello Dr. Nader. Hello Dr. Mahasi.
Hello.
Can you hear me well?
Yes.
Hmm. Wait, let me share my presentation first.
Let me share the agenda and then you can share your screen. So
Okay.
here's the agenda for today's meeting. Dr. Malaz will talk about telehealth or telemedicine in all adults, and then it will be followed by Dr. Safa, who will be speaking about tutorial using Canva, and third one will be Dr. Almar talking about how to master Google Gemini. So without ado, we can continue. The last topic will be by Dr. Fatima Salah. When you are ready, Dr. Malaz, please go ahead.
Thank you, Dr. Nadir. Is it clear?
Yes.
So, hello everyone. I would like to begin by expressing my sincere gratitude to Dr. Nadir for this guidance and for the opportunity to present today. My name is Dr. Malaz, and it's a privilege to discuss a subject that is reshaping the foundation of modern clinical practice, telehealth and geriatric care. As healthcare professionals, we are facing an undeniable reality. The global population is aging rapidly, and with aging comes complexity, multimorbidity, polypharmacy, functional decline, a cognitive impairment, and increased vulnerability to complications. So those with the highest need for medical follow-up and are often the ones who face the greatest barrier to accessing care. This widening gap between medical necessity and accessibility challenges us to rethink traditional healthcare delivery models. In this context, telehealth is not merely a technical convenience, it's a transformative clinical strategy capable of enhancing continuity of care, optimizing chronic disease management, reducing preventable hospitalization, and supporting safe, independent aging. However, its implementation in geriatric populations requires more than technology. It demands sound clinical judgment, individualized adaptation, and strict consideration of ethical and legal framework. Therefore, the question is not whether telehealth should be integrated into geriatric practice, but how we as clinicians can implement it responsibly, effectively, and sustainably to improve patient outcomes. And to translate this vision into structured clinical practice, today's session is guided by clear and focused objectives. By the end of these presentations, we should be able to approach geriatric health in a systematic and clinically sound manner. So first, we will identify the 6 major classifications of telehealth. Understanding these categories is essential because telehealth is not a single intervention, but rather a framework composed of multiple modalities, each designed to serve different clinical purposes. Second, we will examine the clinical indications for each modality. Telehealth must be applied selectively and appropriately. Not every condition is suitable for remote care. Therefore, clinical judgment remains central in determining when and how to use each approach. Third, we'll discuss how to be effectively prepared for a video visit with an elder adult, particularly in presence of hearing, visual, or cognitive impairments, as well as technical limitations such as poor internet connectivity. This is especially important in geriatric practice where functional adaptations determine the success of the consultation. Finally, we will address the major policy, legal, and ethical considerations that influence telehealth implementation in geriatric care because clinical excellence must always operate within a responsible regulatory and ethical framework. So with these objectives in mind, we can now move into core important of the geriatric telehealth practice. So to achieve these objectives, we will exploring the following key domains. First, asynchronous telehealth. We begin with asynchronous telehealth, also known as stored and forward communication. This includes secure messaging and electronic consultations, and it allows clinical information such as reports, images, or laboratory results to be reviewed at a later time. This modality is particularly useful in dermatology, wound assessment, and specialist consultations. Synchronous telehealth. So next, we examine synchronous telehealth, which is involved real-time interactions. This includes clinician-to-clinician consultation, telephone encounters, and video visits with patients. Synchronous care is especially valuable in medication adjustment, chronic disease follow-up, and mental health assessment. And remote patient monitoring, we will also discuss it, a high impactful tool in geriatric medicine. Through digital devices, we can continuously monitor blood pressure, glucose levels, weight changes, and other vital parameters, allowing early detections of clinical deterioration and preventing hospital admissions. Reimbursement, ethical, and legal consideration. Finally, we will analyze policies and the ethical and legal considerations surrounding geriatric health, issues such as patient privacy, informed consent, license regulations, and digital inequality must be carefully addressed to ensure equitable and safe healthcare delivery. So to begin our discussions, it is important to first establish a clear definition and understanding the current landscape of telehealth implementation in older adults. And according to World Health Organization, telehealth is defined as delivery of healthcare services when distance is a critical factor by healthcare professionals using information and communication technologies. This definition emphasizes two key elements: distance as a barrier and technology as a bridge that connects patient to care. So implementation has lagged in older adults. Despite the rapid global expansion of telehealth, its implementation in older adult population has historically lagged behind. For example, national data from 2019 shows that among adults aged 50 to 80 years, only 4% had experienced a real-time telehealth visit in a prior year. So this highlights a significant gap between availability and utilization. However, emerging evidence suggests that when appropriately designed and supported, telehealth modalities are both feasible and acceptable to older adults across various clinical settings. This challenges the common assumptions that older adults are unwilling or unable to engage with digital healthcare solutions. And nevertheless, several barriers continue to limit widespread adoption. These include disparities in internet access, limited device ownership, low digital literacy, and accessibility challenges related to sensory or cognitive impairment. So therefore, while telehealth offers significant potential, equitable implementation requires targeted strategies to address these structural and functional barriers. So understanding these backgrounds allow us to approach telehealth in geriatric not as a simple technological solution, but also complex clinical interventions that require a thoughtful integration. So with this foundation in mind, we can now explore the different telehealth modalities in greater details. So let's now examine the different types of telehealth modalities and understanding how each one functions within geriatric clinical practice. So telehealth can be broadly categorized into clinical care and educational modalities. Within clinical care, we primarily distinguish between asynchronous care, synchronous care, and remote patient monitoring. Asynchronous telehealth involves the exchange and review of health information outside of real-time interaction. It allows data to be transmitted, stored, and evaluated at a later time. Examples include secure messaging through patient portals, communication between clinicians, and electronic consultations. Synchronous telehealth, in contrast, synchronous telehealth refers to real-time interaction between patients and clinicians, such as live video visits or telephone encounters. Remote patient monitoring focuses on ongoing data collection from patients in their home environments, allowing early detection of deterioration in chronic conditions such as hypertension or diabetes. And last, education, clinician to clinician. Additionally, telehealth supports clinician to clinician education and collaboration, such as programs like ECHO, which extend specialist expertise into community settings. And and having outlined the overall structures, we now explore asynchronous telehealth to greater depth. So asynchronous telehealth, also known as store and forward, refers to transmission and review of clinical information outside of real-time interaction. What makes this model distinct is that clinical decisions making becomes data-driven rather than time-independent. So the clinician and patient do not need be present simultaneously. Instead, health information is collected, stored, reviewed, and acted upon when clinically appropriate. So this will secure messaging between patients and clinicians. One of the most widely used applications is secure messaging through patients' portals. This facilitates medication. This facilitates medications clarification, symptom updates, laboratory follow-up, and environmental and reinforcement of care plans. And this evidence has demonstrated improvements in patient satisfaction, behavior access, communication quality, and even retention in care. So, however, in geriatric population, digital literacy becomes a clinical determinant. So, older adults with lower health literacy may require structured onboarding and repeated training to effectively use patients' portals. And additionally, caregivers often act as intermediaries and must be included in the communication process with appropriate consent. So while patient-clinician communication is essential, asynchronous telehealth extends P1 individual interactions to impact interdisciplinary coordination. So secure messaging among interprofessional team members in geriatric medicine care is inherently multidisciplinary. So secure asynchronous communication between physicians, nurses, pharmacists, and home health teams improves coordination. It reduces delays into decision making and supports shared care planning. And identified as a core quality indicators in home-based primary care and palliative care models structures, asynchronous communication has been identified as a as quality indicator. So this reflects its role in maintaining quantity and preventing fragmentation of care. And reduction in emergency visits. Importantly, studies conducted in senior living communications have shown associations between asynchronous coordination and fewer emergency department visits for ambulatory care sensitive conditions. So this suggests that early communication and proactive management can prevent clinical deterioration. So in this sense, asynchronous telehealth act as preventative strategy rather than reactive one. Particularly structured and high impact application of asynchronous telehealth is the electronic consultations or e-consultant. So electronic consultation or e-consultant allow primary care providers to seek focused specialist input on specific clinical questions without requiring a full in-person referral. So primary providers perspective. From the primary provider's perspective, e-consultants improve access to specialty expertise and may reduce unnecessary referral. However, this may increase cognitive workload as primary clinician remains responsible for interpreting and implementing the specialist recommendations. Patient's perspective. From the patient's perspective, e-consultants reduce travel burden, shorten waiting times, and minimize exposure risk. And however, the absence of direct interactions with the specialist may limit opportunities for clarifications or shared decision making. And finally, a specialist perspective. From the specialist perspective, e-consultants enable efficient, focused input. Yet for complex cases, compensation structures may not adequately reflect the time and expertise required. So additionally, implementing complex specialty recommendations is in frail older adults may require careful contextual adaptation by primary clinician. So overall, asynchronous telehealth enhances communication efficiency, improves interdisciplinary coordination, and expands access to specialty expertise. However, its effectiveness in geriatric care depends on digital inclusivity, um, structured implementation, workload balance, and careful clinical judgment. It's not a replacement for clinical interaction, but rather a complementary tool with a broader continuum of care. So after examining asynchronous telehealth, where communication is time independent and information driven, we now transition to synchronous telehealth, a model grounded in real time clinical interaction and immediate collaborative decision making. First, synchronous telehealth is clinician to clinician. Telehealth represents structured real-time collaboration aimed at enhancing expertise distribution and improving system-level outcomes. So first we have scan echo. Scan echo is refers to regular teleconferences in which a primary care clinician, particularly in rural or underserviced area, present complex cases to a specialist via live video. So specialists provided two critical components. First, individualized management recommendations, and second, structured didactic teaching. So these dual approaches transform the model from simple consultations into capacity building. So in geriatrics, where complexity is norm, this model strengthens frontline providers' confidence and clinical competence. Then we have eco care transitions. So eco care transitions facilitates real-time communication between hospital team and interprofessional clinicians at skilled nursing facilities. So this is structured collaborations aim to reduce fragmentation during transitions of care, a high risk period for older adults. So the reported outcomes include reductions in length of stay, rehospitalization rates, and overall costs. So the evidence strength is graded as SOEP, which is mean the moderate quality evidence support these findings. Okay, so the other eco models um, studied across broader population have demonstrated improved provider competence and patient outcomes. So here, the strength of evidence is SOE, which is A, indicating a high quality, consistent data. So while these models emphasize professional collaboration, geriatric telehealth must be extended expertise directly to patients, particularly in geographical isolated areas. So we have virtual geriatrics hub and spoke model. Virtual geriatrics operates through a hub and spoke framework. So geriatric centers function as hubs delivering consultations to rural and their primary care clinicians. This method integrates synchronous evaluations, asynchronous e-consults, and structured education through webinars. So results suggest preliminary results suggest improved access to geriatric expertise. So the evidence strength remains SOEP. So this reflecting promising but still evolving data. Social media expansion. Social media platforms may expand educational reach, for example, through streaming grand rounds. Um, so this access to subspecialty knowledge. And we have COVID-19 COVID-19 impact. So during the COVID-19 pandemic, geriatrics education rapidly transitioned to webinar-based platforms, accelerating digital transformation. So moving from clinician collaborations, we now examine synchronous telehealth encounters directly involving older adults. So here we have synchronous telehealth uh, telephone encounters. In this slide, we are discussing synchronous telehealth conducted through telephone encounters. So telephone visits are often more universally accessible than video visits, particularly for older adults who may lack broadband access, smart devices, or technical literacy. So before discussing each point, I would like to clarify the abbreviation SOE, which appears throughout this slide. SOE stands for Strength of Evidence. It reflects the quality, consistency, and reliability of the avoidable research supporting a specific intervention. So SOEA, which indicates high quality evidence, typically derived from well-designed randomized controlled trials or multiple consistent studies. SOEP represents moderate quality evidence, meaning findings are generally reliable but may have some limitations. And SOEC indicates lower quality or limited evidence, often based on smaller studies or less consistent results. So first, mental health assessment, psychotherapy is SOEP. Telehealth-based mental health assessment and psychotherapy have demonstrated moderate quality evidence of effectiveness. This means that there is reasonably consistent data supporting their benefit, particularly in managing depression and anxiety among older adults. Follow-up of patients is started on psychotropic medications, SOEC. Follow-up of patients initiated on psychotropic medication may improve depressive symptoms and overall well-being. However, the strength of evidence here is graded as SOEC, which is indicating that the data is more limited or less consistent. Therefore, while promising further research is needed. Then assessment of fall risk and physical activity promotion, which is SOEC. So telephone encounters can also support fall risk assessment and promotion of physical activity as part of a comprehensive risk reduction strategy. So again, SOEC suggests that while feasible, stronger evidence is still required. Increasing physical activity via text message and internet-based programs is SOEA. In contrast, text message and internet-based exercise promotion program have strong evidence classified as SOEA. This indicates high quality data supporting their effectiveness in increasing physical activity among older adults. And then improving pain and disability, which is SOEP. So telephone interventions may also improving pain control and reduce disability. So the evidence here is moderate, which is SOEP. Supporting smoking cessation, behavioral counseling delivered by telephone has long been recognized as effective for smoking cessation. So although no SOE grade is specified here, so evidence in broader population support its effectiveness. Screening for cognitive impairment. So cognitive screening can be performed via telephone. However, not all instruments are validated for all population. So this highlights the importance of selecting appropriate validated tools based on patient demographic and clinical context. So in summary, telephone encounters remain a highly accessible and clinically valuable modality within synchronous telephone. So although evidence strength varies depending on the intervention, telephone-based care plays a critical role in maintaining continuity, particularly for elder adults with limited technological access. So After discussing the importance of cognitive screening during telephone encounters, it becomes essential to identify which tools are validated and appropriate for remote assessment. This slide outlines selected cognitive screening instruments specifically adapted for telephone use. So it's important to emphasize that not all cognitive tools validated for in-person use are suitable for telephone administration. Therefore, selection must be guided by validation studies, require training, appropriate restrictions, and specific cognitive domains being assessed. So first, telephone interview for cognitive status, TICS. It's one of the most widely studied telephone-based cognitive screening tools. It primarily evaluates orientation, attention, memory, and language. It's particularly useful in large epidemiological studies and follow-up assessments. Telephone Montreal Cognitive Assessment, which is TMOCA, refers to telephone version of the Montreal Cognitive Assessment. It's adapted from the standard MOCA, mild cognitive, which is commonly used for detecting mild cognitive impairment, and the short version of TMOCA short is also available. So importantly, training and certifications are mandatory to administer this test. So this ensures standardizations and reliability. Then we have ALFI MMSE, which is telephone version of a mini mental state examination, which represents a telephone adapted version of the mini mental state examination. Similarly, T3MS refers to the telephone adaptation of modified MMSE, and it's important to note that some of these instruments are proprietary, meaning they require license for use. Then we have 88 dementia screening review. Is a brief dementia screening interview. Unlike many cognitive tests, it's information based. This makes it particularly valuable when the patient has limited insights into cognitive decline. Then we have HVLT, which is a Hopkins verbal learning test. It focuses primarily on verbal memory and learning. It's useful for detecting early memory impairments. Then we have TAMS, which is telephone as mental states. It's structured to assess global cognitions via remote administration. Then we have TICSM, which is modified telephone interview for cognitive status. It opens the original TICS by incorporating additional memory and exclusive functional components. And then we have TIMC, which is placed telephone information memory concentration test. It evaluates information recall, memory retention, and concentration. And then we have STIDA, which is referred to a structured telephone interview for dementia assessment. It's designed specifically to support structured dementia evaluation. Then we have MCAS, which is Minnesota Cognitive Equity Screening. It's other structured telephone-based cognitive screening instruments. And also we have BT Act, which is referred to brief test of adult cognitive by telephone. It assists multiple domains, including memory, reasoning, and processing speed. So, in summary, multiple validated instruments are available for telephone-based cognitive screening. However, tool selection must be individualized. So, clinicians must consider the validation data, training requirements, liaising restrictions, patient literacy, and sensory limitation. So, telephone-based cognitive screening enhances access, but clinical interpretation must always remain cautious and context sensitive. So after discussing telephone encounters with prioritized accessibility, we now move to video encounters, a modality that expands clinical assessment capabilities while maintaining real-time interaction. So, a rapid evolving area of care. Video-based telehealth represents a rapidly evolving area of care. During the COVID-19 pandemic, regulatory requirements were relaxed to facilitate access. So this regulatory flexibility accelerated widespread adoption and demonstrated that video visits can be integrated safely into routine clinical practice. So the benefits ability to perform parts of the physical examination. One major advantage of video encounters is the ability to perform selected components of the physical examination. Through direct observation and guided patient participation, clinicians can assess affect respiratory effort, gait tremor, edema, and even certain functional tasks. Although not equivalent to in-person examination, video allows clinically meaningful visual assessment. Second, expansion of geriatric expertise. Video visits also expand geriatric expertise to patients who may be unable to travel to clinical due to frailty, transportation barriers, or caregiver limitations. So this is particularly relevant in rural or underserved populations. Regarding limitations, various technical literacy required. So, however, successful videos visits require a baseline level of digital literacy, as we know. So, older adults with sensory impairment or cognitive decline may struggle with device navigation. And second, challenge of establishing support. Uh, challenge of establishing rapport. So establishing therapeutic rapport can also be more challenging without physical presence. So that means non-verbal cues may be particularly limited, and subtle emotional dynamics can be harder to interpret. So, given these benefits and limitation structures, preparations becomes essential to ensure safety and equity. So, preparing for a video visit with an elder adult is not optional in geriatric telehealth. It's a safety requirement. So first, we have to verify that the patient has high-speed internet and a device equipped with a webcam. Equally important is confirming the patient's ability to access and operate the video platform. Use two monitors if available, if possible. So using two monitors improves efficiency. One dedicated to the video interaction and the other for reviewing the electronic health record. And verify participants' contact information. All participant contact information should be verified and the technical setup tested prior to the visit. Arrange caregiver or interpreter when needed. A caregiver or medical interpreter should be arranged either on site or virtually. Ensure privacy. Both patients and providers should be in a private, quiet setting to maintain confidentiality. Verify location and obtain consent. At the start of the visit, verify the patient's physical location and the presence of anyone else in the room. Verbal consent must be obtained to conduct the telehealth encounter. So, beyond initial setup, contingency planning is equally important. So, obtain technology support and emergency contacts. So, contact information for technical support should be available in case troubleshooting is required. Additionally, local emergency service contact information must be accessible, particularly if urgent issues arise during the visit. Anticipate challenges and mitigation strategies. So, anticipating barriers allow proactive mitigation. So, hearing impairment examples. Hearing impairment. So, for hearing impairment, headphones or closed captioning, if available, may significantly improve communication. Second, vision impairment. For vision impairment, adaptive software, magnification tools, and high contrast display settings can enhance usability. So connectivity issues. If connectivity issues such as lag time or echo occur, switching to a landline for audio or converting the visit into a telephone encounters issues to ensure continuity. So in summary, video-based synchronous telephone expands clinical assessment capabilities and improves access to geriatric expertise. However, its effectiveness depends on preparation, technological readiness, patient-centered adaptation, and planning. So when implemented systematically, video telehealth becomes not merely a substitute for in-person care, but a complementary extension of comprehensive geriatric practice. So to ensure that telehealth remains truly age-friendly, we must ground it in a structured geriatric framework. One of the most widely adopted models is the geriatric 5Ms, developed within the AFHS initiative. So the 5Ms framework were developed, which stands for age-friendly health system. So the 5Ms represent 5 essential domains of high-quality geriatric care. What matters? Medication, mentation, mobility, and multi-complexity. When we adapt telehealth to elder adults, our goal is not only technological access, but preservation of these 5 domains. First, what matters? The first domain, meaning aligning care with the older adults' values, goals, and preference. Assessment during visits, advanced care planning, caregivers building assessment, and observing home environment. So video visits uniquely allows us to observe the patient's home environment, which is provide contextual insight into daily living conditions. So advanced care planning discussions can be conducted in comfortable settings, potentially enhancing the openness. So useful tools, we have vital talk communication guided. We have polished forms, which is order for life-sustaining treatment. Vital Talk, for examples, provide structured communication frameworks for serious illness conversations. Second, medication. So, medication focusing on safety, de-prescribing, and minimizing polypharmacy. So, polypharmacy refers to concurrent use of multiple medications, often increasing risk of adverse events. So during video, patients can physically show their medications bottles, pill, or organizers, and set up, allowing real-time medication reconciliations. So tools we use AGS Pierce criteria, which is the American Geriatric Society guidelines identifying potentially inappropriate medication. So the criteria specifically highlights medications that pose higher risk in older adults. Mentations, the third domain is mentations, referring to cognitions, mood, and delirium. So we in assessment, we assess cognitive screening, delirium screening, mood evaluations. However, results must be interpreted cautiously in telehealth settings. So the tools we use, mini mental state examination, MMSE, and Montreal Cognitive Assessment, MOCA, confusion assessment methods for delirium, which is CALM, and GDS, which is geriatric depression scale. Each of these tools has been adapted for remote or audio visual use, so availability may vary. So while the first 3 MS address values, medication, and cognition, the next 2 focus on the physical functions and complexity. So mobility is central to independence and fall prevention. During video, chair stand test, gait observation, home hazard assessment. For example, asking the patient to perform a 30-second chair stand test provides objective assessment of lower extremity strength. So the tools is 30-second chair stand, CDC study checklist, which is stopping elderly accidents, deaths, and injuries. And we use ADL, which is activities of daily living. So the CATS ADL measures the functional independence in bathing, dressing, um, toileting, transferring, continence, and feeding. Continence, sorry, and feeding. So we assess bathing, dressing, transferring, continence, and feeding. Multi-complexity. So multi-complexity is refers to multi-morbidity, frailty, and complex social or medical needs. So during video, prioritized discussion, frailty assessment, um, which is referred to decreases physiologic reserve and increase vulnerability to stressors. So tools is a frail scale, which is clinical frailty scale, chart-based frailty index. So will help guide intensity of intervention and risk stratification. So having adopted the 5Ms framework to telehealth practice, we must now examine whether the evidence supports this model. So some evidence for adopting the geriatric 5Ms is mentation. Mentation is SOEA. So providing mental health treatment via video is feasible and well accepted. So that means strength of evidence is A, which is high quality evidence. So although cost effectiveness data remains limited, the feasibility and patient acceptance are strongly supported. Mobility is SOEP. So video visits for Parkinson's disease and neurological conditions have shown promising results. However, further research comparing face-to-face and video outcomes is required. B, which is moderate. So medications is SOEA. So pharmacists lead medications reviews via video have demonstrated success in reducing inappropriate prescribing. So this suggests in strong evidence supporting telehealth-based medications optimization. Matters most SOP. So palliative care delivered via video expand access to symptoms management and advancing care planning. However, evidence does not yet demonstrate reduced emergency department utilization. B, which is means moderate. So in conclusion, adapting the geriatric 5Ms to telehealth ensures that virtual care remains person-centered, safe, and evidence-informed. So telehealth does not replace geriatric principle. It must operationalize them. When structured around the 5Ms, telehealth become not simply a technological innovation, but a clinically rigorous extension of age-friendly care. So, after discussing video-based telehealth, I'll now move to remote patient monitoring, or RPM, which is represent a more continuous and proactive model of care. So, remote patient monitoring refers to collection and transmission of patient-generated health data from home to clinician for review and intervention. Unlike a single telehealth visit, RPM allows ongoing monitoring of chronic conditions. VA experience. RPM has been implemented on large scale within the VA, meaning the Veterans Health Administration, particularly among older adults with chronic diseases. So studies from the VA demonstrated fewer hospital admissions and reduces length of stay in year after enrollment. So the indicates is O equals A meaning a strength of evidence A, which is reflects high quality supporting evidence. And then mixed outcomes more broadly. However, outside of structured systems like the VA, data are more mixed regarding outcome improvements. So hypertension, COPD, rehabilitation, although trials show strong evidence quality improvements in conditions like hypertension and COPD, which stands for chronic obstructive pulmonary disease, as we know, and rehabilitation's outcome are modest. So cancer chemotherapy outpatients, uh, chemotherapy patients, so older adults receiving chemotherapy who electronically report systems between visits show improved quality of life and fewer emergency room visits. So this highlights the importance of timely symptoms detection and intervention. So the effectiveness of RPM depends on patient engagement, clinician responsiveness, integration of data into the electronic health record, clear workflows, and timely clinical response. Monitoring without action does not improve outcomes. So, beyond the clinical effectiveness, sustainability of telehealth depends on the reimbursement policy. So, first, we have payment parity. Payment parity means telehealth visits are reimbursed at the same rate as in-person visits. Most private insurers and many states have implemented parity laws. Then we have Medicaid variability. So, however, Medicaid telehealth coverage varies significantly by state, which creates variability in access. Pre-COVID Medicare restrictions before COVID-19, traditional Medicare had strict geographic and originating site restrictions. However, Medicare Advantage plans and ACOs, which is Accountable Care Organization, had fewer limitations. Then, through the CARES Act, the Coronavirus Aid Relief and Economic Security Act, Medicare temporarily expanded the telehealth reimbursement and removed mainly restrictions. Then CMS future rule. The Centers for Medicare and Medicaid Services will determine whether these temporary flexibilities become permanent. Their decisions will significantly impact long-term access for older adults. So, in addition to financial sustainability, telehealth must operate within ethical and legal framework. So, um, privacy and HIPAA. HIPAA stands for the Health Insurance Probability and Accountability Act. So, telehealth platform should complain and both patients and clinicians must be in private settings. Informed consent for telehealth should be obtained and documented. And during the COVID-19 enforcement, discretion allowed use of non-public facing platforms in good faith. And then telehealth raises interstate liaison challenges. So the Interstate Medical Liaison Compact, introduced in 2017, allows eligible physicians to apply for liaison in multiple practicing states. So physicians working for the VA can practice across the state lines. Temporary waivers during COVID allows out-of-state practice in many regions. So additional legal considerations include prescribing regulation, trainee supervisions, and malpractice liability. So control substance prescribing, the Ryan Hyde Act historically required and in-person evaluations before prescribing controlled substances. So the Drug Enforcement Administration, DEA, typically requires separate state registration. During COVID-19, temporary waivers allowed remote prescribing without prior in-person visits. Supervision of trainees, ACGME, the Accreditation Council for the Graduate Medical Education, permits supervision of residents and fellows via telecommunications. However, attending physicians remain legally responsible for care provided under their supervision. Liability and malpractice, the same standard of care applies to telehealth as to in-person care. Clinicians must ensure their malpractice insurance covers telehealth services. Certain physical examination components may be less reliable remotely, increasing diagnostic uncertainty. Broader ethical concerns, there remains uncertainty regarding when an in-person visit is necessary. So there are also concerns about communication quality and limitations of remote physical examination. So therefore, informed consent should reflect both benefits and limitations of telehealth. After discussing clinical, legal, and reimbursement consideration, it is equally important to address equity because telehealth is only effective if patients can actually access it. So we have 10% remain offline. Approximately 10% of adults in the United States remains completely offline. This means they lack internet access altogether. Importantly, being offline is not random. So it's strongly associated with older age, lower education levels, lower income, rural residents, disability, and Black and Latinx ethnicity. Therefore, without intentional strategies, telehealth may unintentionally widen existing health disparities. Device access and comfort. Even when internet access is available, telehealth requires an appropriate device such as a smartphone, tablet, or computer, and a certain level of comfort using technology. For many older adults, particularly those with cognitive, sensory, or functional impairment, a supportive caregiver becomes essential. Then estimates. Powerful statistic. They said that data from 2018 estimated that 1 in 3 adults aged 65 years and older were unprepared for video visits. Among adults aged 85 and older, this increased in 2 in 3, meaning the majority of the adults old were not ready for video-based care. So additionally, 25% of adults over 65 report difficulty even with telephone encounters. So this statistic clearly demonstrates that digital access is not merely a technical issue, it's a geriatric care issue. So recognizing these barriers must be moved beyond identifying disparities and actively implement strategies to enhance access. First, to enhance access to video telehealth, first we have internet access. As a structural level program such as the Federal Lifeline program provides county data plans for low-income households. However, eligibility alone is insufficient. Many patients require assistance navigating enrollment, understanding payment options, and completing applications. Then, digital literacy. Digital literacy is equal critical. Older adults may benefit from structured training programs offered through public The literacy is equal critical. Older adults may benefit from structured training programs offered through public libraries, community-centered or aging services organizations. So providing clear step-by-step instruction before visits can significantly improve successful connection rates. Then device accessibility. Beyond internet literacy, device accessibility must be considered. So this includes simplified smartphone or tablets, larger fonts, high contrast interface, magnification software, and closed captioning options. So assistive tools such as personal amplification devices or adaptive style uses may also enhance usability. So in some cases, referred to audiology, low vision services, occupational therapy, or speech therapy can improve long-term access. Then video visit accessibility. Finally, choosing a simple and user-friendly platform is essential. So when patients are not comfortable, arranging for a caregiver or support person to be present can dramatically improve visit quality and reduce anxiety. So telehealth success often depends more on preparation than on technology itself. So that means having reviewed the evidence, policy considerations, and equity challenges, I will now summarize the key take-home message. So first, COVID-19 catalyzed change. So COVID-19 public health crisis, along with temporary relaxations in privacy, reimbursement, and legal restrictions, catalyzed a profound expansion in synchronous telehealth use among elder adults. So synchronous refer to real-time communication such as video visits. And telehealth modalities can be categorized into three primary modalities. The asynchronous, also known as store and forward, where information is transmitted and reviewed later. Second is synchronous, real-time interaction between clinician and patient. And third is remote patient monitoring, which combines asynchronous data collection with real-time feedback or intervention. And a need for modification. Importantly, modification must be implemented to accommodate patients with hearing impairment, vision impairment, cognitive impairment, or limited digital access. So without these adaptations, telehealth risks excluding the very population it aims to serve. So finally, clinical judgment remains central to safe and effective geriatric telehealth practice. So in clinical judgment, clinicians must determine whether telehealth is appropriate for each specific clinical scenario, and the modality chosen should achieve a standard of care that is comparable to, or in some cases, superior to in-person care. And telehealth should enhance care, not compromise it. Caution with geriatric tools. Additionally, clinicians must exercise cautions when adopting geriatric assessment tools that have not been validated for remote administration, and interpretation of cognitive, functional, or frailty assessment should consider the limitation of the virtual environment. So, in conclusion, geriatric telehealth represents a transformative opportunity to improve access, continuity, and patient-centered care for older adults. However, its success depends not only on technological innovation, but on equity, thoughtful adaptation, clinical judgment, and ethical responsibility. When implemented carefully and inclusively, telehealth becomes not merely a substitute for in-person care, but a powerful extension of age-friendly healthcare system.
Thank you so much. We don't have to go through the cases.
Okay, thank you so much.
Excellent presentation. I think this is important topic, and the importance was great when COVID hit. So people are using the telemedicine or telehealth more frequently now. It's a good tool. Any questions or any concerns or any comments, or you want to share your experience? Thank you. If not, we can move on to the next topic.
Oh, thank you, Dr. Malaz, for this is great presentation. So now we can moving forward to the next topic with Dr. Safa. Dr. Safa, if you are ready.
Hello, hi everyone, and good afternoon. And Ramadan Mubarak to everyone who reserved Ramadan. And thank you, Dr. Milaz, for the information that you provided. For me today, I will present the Kavana video editor and how it may help with the telemedicine. Um, I will share my screen with you guys to be able to see the app. Can you please confirm if you're able to see my screen?
Yes.
Yes, Dr. Safa.
Thank you. Okay, so the Kavana Video Editor is a user-friendly tool that can help with the telemedicine in several ways. The first one will be creating engaging patient education videos by explaining medical condition, treatments, or procedure in an easy way to understand the format. Also, it helped develop virtual waiting room contact, which keep patients entertained and informed while they're waiting for their appointments. Also, produce social media content by sharing health tips, announcement, or updates to engage with patients. It helped us also design telehealth consultation materials by create professional looking slides or video to support virtual appointments. Also, it helped us craft patient onboarding videos by welcome new patients and explain telehealth process. So there is a few tips for using Kavana in telemedicine. Um, the first advice would be keep it concise. Patients have short attention span, so aim for a video under 2 minutes. Also use simple language, avoid medical and explain concept in medical terminology, of course, and explain concept in plain terms. Add virtual, use animation, images, footage, and point and keep viewers engaged to keep viewers engaged. Okay, so this was a brief introduction about the app and how it may use. I will go over and share with you. This is how the app or the website would look like. It have very different portion that we can use it and create an enhanced virtual material to share with patient, help us through the telemedicine. Um, okay. So if you see here, if we go through the Instagram reel, this is how it would show up. You can add the video. Here they have different tempos, they have different style. You can add audio, you can add written also logos to it. For example, here you go for your original video. You can upload from a stock video, anything blank. You can add the audio from here. So this is the basic one. Also, you can subscribe. It unlock more features, advanced feature. Let me show you. I don't have any for now, but this is how you can upload it. This is your main video. You can add as much as you can, and it will play in order in the order that you add them. Here you can add anything to the background. You see the arrow here, the up one, and here you can add the voice. You can record or you can generate AI voice, or they have a few stuff that's saved, but of course you can add your own. You can write, you can add written You can also add written examples. You can also add logos. You can also add pictures. Let me try to upload one to show you how. For example, okay, this one, and let us add an audio to it. You can simply record for voice here to this video and explain what is this video is talking about. Okay, and the sound can be played for all over the video, or it could be for a certain part. You can add more than one. You can add also the text. You see, you can write. You can use the text also by adding here. This is your paragraph.
You can double click on the text. It will open the, yeah, you can edit the text inside.
No, it's not this one.
No, the blue text, the on the screen. Yes, this one. Go up. Double click on this blue text, and it. Yeah. Now you can.
So this is how you will be able to add your text just by typing down what you need. It's typing here, but you're not able to see it. But yeah, this is how you add. Thank you, Dr. Nader. This is how you can add a written paragraph to your videos. Um, You can also download the app and navigate it. You can use different designs. You can also use the audios. You can upload your voice as well, the recording to explain what you are talking about. You can add photos as well. And uh, yeah, I'm a new user to the Kavana, so but yeah, this is the all information that I will share with you. I want to share with you today.
You're doing great. Thank you for sharing. And it's as you can see, it's very simple. It's user friendly. So if you just use your mouse and click on stuff, then you can get. And there are a couple of other videos that shows you how to navigate or how to do these videos. So thank you so much for sharing, presenting this. Any questions? If not, we can move on to the next topic. Thank you again.
Okay, we will move to the last topic in our agenda because the topic number three by Dr. Almar, but due to the situation in Bahrain, she was not able to join to us. So, Dr. Fatma, if you are ready, you can share your screen.
Okay, thank you so much, Dr. Hassan. Is the sound clear?
Yes, Dr. Fatma.
Okay, I would like to start by thanking Dr. Nader for this opportunity. And thank you, Dr. Malaz and Dr. Safa for your presentations. They were very informative. So I will start by sharing my screen. Okay. Is it clear?
Yes.
Okay, perfect. So my topic for today is quality improvement and patient safety. Hopefully you will enjoy this topic as much as I did while I was reading upon it. It was actually very informative. So I would like to start by defining what quality improvement and patient safety is. So, quality improvement in healthcare is a structured approach aimed at enhancing patient care by identifying inefficiencies, reducing errors, and optimizing outcomes. So, key aspects of quality improvement include data-driven strategies, meaning we have to utilize evidence-based practices and data analytics to inform decision-making and track patient outcomes, as well as continuous refinement, in which we implement ongoing efforts to improve processes and standards, fostering a culture of continuous quality improvement, as well as patient-focused care, ensuring that care delivery is responsive to patient needs and expectation, which will enhance the satisfaction and outcomes. So then what is patient safety? Patient safety is a critical aspect of healthcare that aims to prevent errors and adverse effects associated with medical care. It involves creating a healthcare environment where potential risks are identified and protective measures are taken to minimize harm. Common risks include medical errors, for example, mistakes in diagnoses, treatment, or medication administration, hospital-acquired infections, meaning infections that patients acquire while receiving treatment for other conditions, and medication mishaps, errors in prescribing, dispensing, or administering medication. So, why do we care about quality improvement and patient safety? Why is it an important thing? So, in the modern time, healthcare is complex, and patients move through multiple transitions of care, interact with many professionals, and are exposed to high-risk therapies. In such environments, error is an expected occurrence of system complexity. So, we have a module called So Error is Human, which is building a safe healthcare system. This is a 1999 consensus report that was published by the Health Institute of Medicine. So it basically reported or estimated that tens of thousands of deaths annually were attributable to preventable medical errors, fundamentally shifting healthcare towards system-based safety reform. So instead of relying on the competence of individuals, we are essentially creating a system that will prevent medical errors and harming patients. Okay, so understanding system errors. Healthcare errors generally fall into two categories, active errors and latent errors. So what do we mean by each? Active errors are mistakes made at the point of care, for example, incorrect dose ordered, and latent errors are hidden system flaws. So they are issues that lie within the system, like similar medication packaging, poor electronic health record interface, and understaffing. And it's actually reported that poor electronic health record interface has higher levels of burnouts in between residents and healthcare professionals. So we can conclude that healthcare errors are not a one-man problem, but a layered issues, and this concept can be explained by the Swiss cheese model. So I found this really nice illustration. It shows the Swiss cheese model. So it helps us understand that healthcare is a layered issue. As you can see, we have multiple slices of cheese, and each one of these slices has holes, right? So the red arrows shows us that if you layer and stack up enough slices, eventually all of these holes will be covered. And this example right here is basically showing us how this was implemented during COVID times, for example. So we have to practice distancing, we have to wear masks, we have to implement cleaning and hand washing. So if any of these steps were breached, then we have another layer that can help us prevent errors from being made. Okay, so how do we investigate these errors and how do we prevent them from happening? We have a concept known as the root cause analysis, which is essentially an investigation. It's a retrospective investigation that follows an adverse event, an error that happened in time, and it seeks to identify uh, contributing human factors, environmental conditions, communication breakdowns, and workflow inefficiencies. So, how do we make sure that our root cause analysis is effective? So instead of implementing superficial fixes like we have to sit down the staff and re-educate them, we instead focus on sustainable structural changes. An example of these changes is implementing a standardized protocol, forcing functions in electronic systems, and redundancy in high-risk steps. So I think giving examples would help us better understand what we mean by these structural changes. So let's say we are in the OR and we have a patient that we are wheeling in for a surgery. Instead of just relying on memory, we have to have a checklist to make sure that everything we need is present and everything that concerns the patient has been addressed before they are wheeled into the OR. Another thing is, let's say we are trying to administer a high-risk medication. So if we look at the electronic health interface, there can be a pop-up window that tells you that you cannot administer this medication or this dose of medication unless this patient has a certain weight. So the certain weight you input in the system has to match the dosage. Okay. So now quality improvement has methods or methodologies, and these methodologies differ from research. How does it differ from research? It basically focuses on local processes improvement rather than generalizable knowledge. So we have to actively investigate the issues that we have in our healthcare setting and try to resolve them. The most commonly used model is the PDSA cycle, and PDSA stands for plan, do, study, and act. So in planning, we identify a problem and we plan an intervention to the problem. And then in do, we implement this intervention on a smaller scale. And then in study, we analyze the outcomes of our intervention. And then in act, we modify and expand this intervention if it was effective. And then it's basically a cycle of doing the same thing until we reach an intervention that can be implemented to improve the investigated issues. So this iterative model promotes continuous improvement rather than one-time policy changes. So where do we implement these or where do we get these ideas? Where are we taking all of these ideas from? There is something called high reliability organizations, and a high reliability organization essentially is an organization that consistently operates in complex, high-risk environments while avoiding catastrophic failures through disciplined processes, mindfulness, and a culture of safety. So an example of these high reliability organizations are aviations and nuclear settings. So what these organizations implement, they demonstrate preoccupation with failure. So they are always focusing on their failures and they are trying to micromanage all of the issues that led to said failures, sensitivity to frontline operations, reluctance to oversimplify their issues, and commitment to resilience. Healthcare increasingly models safety strategies after aviation and nuclear industries, as we mentioned earlier. So a nice example of this is surgical safety. So surgical safety improvements after implementation of the WHO checklist illustrates system-level risk reduction. So this checklist contains 19 items that are divided into 3 phases: the sign-in phase, the timeout phase, and the sign-out phase. So the sign-in phase which is pre-anesthesia, confirms the patient's identity, surgical site, allergies, and anesthesia safety checks. And then the timeout or pre-incision ensures the entire team pauses to verify the procedure, patient, and critical safety steps. And in the sign-out post-procedure, it confirms the instrument counts, specimen labeling, and any post-operative concerns. And this intervention significantly reduced post-operative morbidity and mortality across diverse healthcare settings. So by implementing or standardizing these checklists, you can imagine how many errors were prevented from happening. Okay, so the core domains of patient safety. In quality improvement, efforts typically target medication safety, infection prevention, diagnostic accuracy, communication and handoff, and procedural safety. For example, central line associated bloodstream infections were dramatically reduced through standardized insertion bundles, sterile technique enforcement, and checklist utilization. Okay. So how do we ensure patient safety in daily clinical practices? So clinicians contribute directly through something called closed loop communication. This is a three-way process, or actually a three-step process, where the sender transmits a message, and then the receiver repeats or reads back the message to confirm understanding to the sender, and this will be again confirmed by the sender to prevent errors. Okay, and we have also something called structured handoffs, known as the SBAR framework. S stands for situation, B for background, A for assessment, and R for recommendation. Essentially, what this means is during handoffs between healthcare workers, these four things must be covered about each and every single patient. Another thing is medication reconciliation, which essentially means that we have to sit down and review all of the medication that our patients are taking and make sure that they are comprehensive and none of them are harming the patient, and that their benefits are basically more than the side effects, if there were any. Also, we have to report near misses and speaking up in hierarchical settings. So these last 2 points are more accessible if psychological safety is ensured to healthcare providers. So psychological safety is critical, and if team members fear retaliation, hazards go unreported. So the goal is to shift culture from blame to prevention while balancing accountability. Another thing is quality improvement depends on measurement, because nothing screams measurement more than numbers and data, right? So key metrics include mortality rates, readmission rates, hospital-acquired infections, adverse drug events, and patient-reported outcomes. And as we know, data is crucial for improvement because it helps us to target the most urgent matters so we can implement all of the quality improvement and patient safety measures that we spoke about earlier. Okay, so we have a case example here. Let's say we have a hospitalized patient who developed severe hypoglycemia after receiving an incorrect insulin dose. How can we handle this error? So the first thing that would come to mind in one of these situations is who administered this dose? So instead of pointing fingers, actually, it's better to ask system-based questions. So was insulin stored next to lookalike vials? Were barcode scanners functional? Was staffing adequate? Was dosing protocol standardized? And a sustainable solution to this issue likely involves a standardized insulin order set, barcode enforcement, storage redesign, and staff workflow modification. So this shows us, as we spoke earlier, that oversimplification of these issues can lead to even more errors in the future. And instead, we can build a sustainable solution that involves a framework that dissects each of the layers of these issues. So, patient safety is not the absence of error, it's the presence of systems that anticipate, intercept, and learn from error. So, quality improvement requires structured methodologies, cultural transformation, continuous measurement, and interdisciplinary collaboration. And the safest systems are not those that assume perfection, but those designed to function safely despite inevitable human imperfection. Okay, so this was the end of my presentation, short and sweet, and I hope you guys enjoyed it. If you have any questions, please go ahead.
Thank you so much, Dr. Fatma. And this is also excellent presentation, as you said, short and sweet. Any questions or any
Thank you
comments?
so
Any?
much.
Yeah.
Thank you so much, Dr. Nader and Dr. Fatma and you all. Just Dr. Nader, I want to say, like, I want to leave the meeting, okay? Because, like, we received that due to the current situation and so on, we have
Sure.
to stay in the closest secure
Yeah.
building and so on.
Yes, yes.
I'm
Please
sorry.
be safe and hopefully.
Just regarding the research project and so on, we finished the data. We finished the data extraction and so on. Right now we are working the abstract. So I'm gonna leave now and
Yeah.
thank you so much.
Stay safe. God bless. Thank you. Hopefully people in the area will be safe. We heard it's going to be going on war there. Any comments or any updates? Any new ideas for the projects? I have good news. One of the abstracts submitted to Alzheimer conference was accepted. So we will inform the team so that they can prepare the poster. It will be in Turkey, I believe, this summer. Any general question about the fellowship, about the topics, about anything that you need us to focus on or address? If not, then I'd like to thank you so much, Dr. Hassan, and all the presenters and all of you who attended this meeting and those who will come to watch the recording in the future. Thank you all, and we'll see you next week. Have a wonderful day. Enjoy your Ramadan if you're fasting and observing Ramadan. Otherwise, I wish you all the best. Have a good night or good day. We'll see you next week. You can reach me by email or text or call or WhatsApp. If you need any help, we'll be happy to assist you guys. Assalamu alaikum. في أمان الله.
Thanks, Dr. Nader and the presenters. Thank you.
Thank you so much, Dr. Fatma.
Thank you, Dr. Nader.
You're welcome, Dr. Nahed. Thank you so much.
Bye.
Bye.